Hello, I'm Alexander Mostovoy, board-certified clinical thermologist. Today, I would like to talk to you about one very important subject. Why thermography? There can be so many different tests, so many different technologies. What's so important about thermography and why is it so useful? Let me take a few moments and walk you through some of the things that I find important. Now, let's just imagine that 3 jumbo jets with 550 passengers each crash each and every day of the year. Would you still fly? That's 650 people die each and every year due to airplane crashing. I doubt that any one of you would still have any confidence in aviation industry. And yet, we have the same number of women dying from breast cancer, and for some reason, we continue to fly in the same direction. Breast cancer statistics, well, this year over 2 million women worldwide are going to be diagnosed with breast cancer. In the United States and Canada alone, 300,000 women will be diagnosed with breast cancer. 550,000 women worldwide will pass away from breast cancer this year. When we talk about statistics, we need to realize that these are not just numbers. These are women. These are mothers, wives, sisters, grandmothers. These are usually kind of the heart, the center of the family unit. So it's not just them, although it's very tragic, but the entire family is affected. So we can't just look at this as numbers, statistical kind of probabilities. All I wanted to point out is that I'm sure almost everyone who is listening to this either has been affected personally or knows someone who has been affected. So let's take this thing seriously. As far as I'm concerned, there are 3 problems. The problem is that the current paradigm. Another problem is that there is no active preventive measures that are being advocated by the medical community, by the government. And the third problem is that we have confused screening with risk assessment. Let me explain what I mean by this. First of all, the current paradigm, and I like to use this analogy of as you can see, a beautiful iceberg. Now the iceberg is only 10% above the water. 90% is below the water. So if we only concentrate on how the top part, in other words, the lesion, or in this case, the visible iceberg, whether it's becoming bigger or smaller, that's basically the most important criteria right now. And yet, 90% of that iceberg, or 90% of that tumor, I should say, is not been addressed. So naturally, prevention outweighs cure anytime. Anyone who's been through breast cancer or knows someone who's gone through breast cancer, specifically the very invasive therapies that are involved, will opt out for prevention anytime. Now, let me explain the difference between risk assessment and screening. So first of all, risk assessment is something to do with the probability of what is going to happen. When screening is basically, we're screening for something that already happened. So we use thermography, and I advise anyone who's listening to this to look at thermography as a functional test, because it is a test of function, and it gives us a pretty good probability of what will happen versus mammography, ultrasound, MRI as a structural test, which basically tells us something is there already. But that something does not develop overnight. We know that by the time lesions or tumors are detected by mammography, in many cases, it takes 8 to 10 years to get to that level. In other words, if we're looking at something, let's say year 5, and it's not detectable by structural tests, does that mean it doesn't exist? Right? And again, I'm not just opposing thermography versus mammography or ultrasound or MRI. I'm not saying one is better or the other. They all have their function. They all have their place under the sun. And we have to use all of the technology available for this. There's also problems with screening because the medical community in many, many ways is handcuffed. This is the standard of practice. And if you deviate from the standard of practice, well, you know what's going to happen. Another problem is the actual system. The system is basically a conveyor belt. So as long as you fit into that system, into that conveyor belt, and as long as you move along that conveyor belt, you may get some relief, and many people do. But as we all know, we are all very, very different. And the way we're raised, the way we eat, the way our physiology, the way we think affects us. So needless to say, if you don't fit on this conveyor belt, then it is very unlikely that the system and the way it's designed is going to help you. There's another thing called screening illusion. So basically today, with the media and even in some cases with the medical community, detection is almost equated to prevention. If we can detect it early, then your chances of survival is much, much higher. Well, nobody's going to argue with that. However, we cannot equate detection with prevention because these are two different things. Let me explain what I mean by lead time bias that inflates survival statistics. Take a look at Exhibit A. In other words, here we have the biologic onset of disease, year 1985. Diagnosis and treatment starts in 1992. Unfortunately, death occurs in 1995, so there is a survival rate of 3 years. Now, let's look at the Exhibit B. Again, the same biologic onset of disease in 1985. However, with early detection, instead of 1992, we detected this patient's tumor in 1989. However, death still occurred in 1985. So you can say, well, look at this. Survival rate is phenomenal. We've increased this person's lifespan by 3 years. Well, if you look at the Exhibit C, I beg to differ. Yes, we did detect this person's lesion earlier, but the end result was still the same. In other words, we didn't really extend this person's life by 3 years. We had a lead time, which is called lead time bias, for 3 years. In other words, this person has been treated, and most likely not, the treatment is not something that you want to kind of volunteer for or wish on your enemies for 3 years prior to kind of the usual diagnosis and treatment. So this is called lead time bias, and it's a very important point that I wanted to bring up. Mammography does not save lives. Of course, it is a very important test. And I wish we had something better than this because mammography happens to be probably the most controversial test in the past 40 or 50 years. And, you know, I am very kind of, I'm fine when people use mammography for diagnostic purpose, not necessarily for screening, but that's my personal opinion. In this particular case, in the New England Journal of Medicine, we can see that over 1 million, 1.3 million women were overdiagnosed in the past 2 decades. What does that mean? It means that women who did not have cancer were actually treated either with biopsy or radiation or chemotherapy in some cases, or by other means. They actually didn't have cancer. I have to say that 25% of all mammographic positive tests are ductal carcinoma in situ, DCIS, and this is stage 0 cancer. So make your own kind of conclusion about that. Now, the problem also is that mammography is not really specific to different shapes and sizes. So someone who is a little bigger or someone who is a little smaller in terms of their chest size may not fit well into mammography plate. And another issue is that young women with dense breast, mammography is not appropriate for this type of testing, and this is why you know, even kind of the practice is to get women to start testing them with mammography past 40 or past 50. Also, women with fibrocystic breast, mammography is not specific for that. You need an ultrasound for this. So where does thermography come in as a risk assessment? I'm showing you pictures here from 2003 Hong Kong airport. And I find it's almost deja vu that we are looking at this, and you can see that basically almost in any airport today, because we're dealing with, instead of here, SARS-1, now we're dealing with SARS-2. So what does it do? We're looking at temperatures of people. In other words, if you have a temperature over 37.5 degrees, it means that you might have fever, and it is very unlikely that you are going to be boarding that plane. Now, here you can see an image of a thermal camera looking at people's faces. You can even screen a whole crowd and pick up people with obviously higher facial temperature. And that's a good reason to pull them aside and make sure that you know, we can measure temperature otherwise and see if in fact they do have fever. So things like that have existed for many years. Of course, unfortunately, has come back with way more kind of problems that we ever expected to see with SARS-2. But technology has been there, and in this case, we're using for fever screening. But when it comes to disease progression, I just want to explain, this is obviously just my kind of opinion, that disease starts on a non-physical, energetic level. And then it descends to functional level. In other words, it descends to the cellular level, which is detected by thermography. And then the later stage, it descends to the structural level. Remember, function versus structure. Function always precedes structure. And finally, the end stage of that disease is something that nobody really wants to talk about. So the benefits of thermography: first, it's non-invasive. There is no radiation. There is no contact. It detects inflammation. And finally, it is a physiological or a functional test. Now, we all know that angiogenesis is a hallmark of cancer. Let me take a moment and explain this slide to you. We all have small colonies of malignant cancerous colonies that are flowing in through our bodies on regular basis. However, the only time they become problematic is when they attach themselves to blood supply. Why do they need blood supply? Well, because they are growing much faster than normal tissue. They need nutrients, and they get nutrients through blood supply. So as they attach to that blood supply, that's when they become problematic. So angio means blood, and genesis, as we all know, in the beginning of this process. So if the angiogenesis is a hallmark of cancer, why not use this information in terms of risk assessment or really earlier detection? We also know that when we put people with cancer on anti-angiogenic drugs, in other words, drugs that are suppress blood supply to that area, that tumor shrinks, and as we take them off and allow blood supply to that tumor again, that tumor starts growing again. And this exactly is what we're measuring. Most of the heat that we see, let's say, in breast comes from blood supply. So do you see the difference here between this breast and this breast? Of course you do. And let me explain what is it that you're looking at for those of you who have never seen a thermal image before. These bunch of numbers are degrees in Celsius. The darker colors are cooler temperatures, the lighter colors are warmer temperatures. And then eventually it washes out to white. So naturally you will have heat under your breast, you will have heat around your axilla, around your carotids, and so on. But when we see an asymmetrical, a unilateral presentation like this with elevated nipple temperatures, with this whole formation, it becomes very, very risky. It's problematic. So we need to investigate that further. And here, yes, we want to use a structural test like mammography, ultrasound, MRI. There's nothing wrong with that. We need to find out if there is something that's detectable already. And if it's not, fine. As I want to suggest, what do you do with this information if, let's say, it's not corroborated by mammographic testing? Well, sit down with your healthcare professional and go over what is putting you at risk. Maybe it's your hormones, maybe it's your diet, maybe it's your psycho-emotional state, maybe it's your endocrine disorders like hypothyroid. Maybe there are so many different things you can look at holistically, and one by one try and reduce those risk factors. And that's how you may avert, in other words, or prevent things from happening like this. Now, breast cancer, again, if you're looking at the right breast here, this particular redness is so obvious that it also involves the axilla. And as you can see here, it probably involves the lymphatic flow and possibly even the lower right jaw. I will be talking about dental pathology and breast cancer in my other presentation today. So please, if you have a chance, take a look at this as well. Now, thermography could also be used as treatment monitoring. This woman came to us and on her first image, we look at this. Wow, she's lighting up like a Christmas tree. And what does that mean? It probably means that she is hormonally imbalanced, or she's in a state of estrogen dominance, as we'd like to call it. Well, 6 months, And with I3C or indole 3 carbinol, indole 3 carbinol is made from cruciferous vegetables. You can use that, or you can use DIM, or you can use both if you like. Some women respond better to others than with DIM or with IC3. See what works for you. Now look at this image. The whole thing cleared up. In other words, she goes from fairly elevated risk because, it's anything could happen here, to a low risk situation. And that I3C is an over-the-counter supplement that you can probably buy for $20 a month supply. Dental pathology and breast cancer. Well, in this particular case, we're looking at something is going on with the right breast here, and something is going on with the upper as well as probably lower jaw with the same patient. With this patient, I decided to escalate, and unfortunately, this small thing happened to be a very late stage breast cancer, even though she was kind of screened on a regular basis before. TMJ analysis in breast cancer. Again, I will go into this subject in more detail. I just wanted to bring this up, that TMJ is temporomandibular joint disorder. In other words, the upper and the lower jaw connect. Sometimes some people will say that when I chew, my jaws click. That's an indication that maybe you should be checked for TMJ. Or you can have thermography and see if there is a difference in temperature from side to side. We also found that in many cases that people with TMJ are also highly predisposed to breast cancer. In this case, you can look at the breast here. I think it's quite obvious what's going on. How do we rate thermal imaging? In other words, this whole thing is based on your score, and it's based on a TH rating. TH stands for thermal. It's an internationally accepted rating all over the world. So TH1, where you can see hardly any activity, and that's going to be with a fairly low score of 0 to 29. TH2, some asymmetrical activity is noticed, and the score may be between 30 and 74. That's TH2, still low risk. TH3, definitely asymmetrical formation of blood vessels, usually a unilateral presentation, and that's going to be, again, between scores of 75 to 119. That is medium or equivocal risk at this point. And finally, we get into TH4 and TH5. You can see TH5 is quite obvious thing here with a very high score. What does that mean? This is all based on statistical probability of risk. In other words, I cannot say that this is breast cancer even though this is TH5. Of course, I'm highly suspicious. Only biopsy can determine whether or not this is malignancy. Mammography cannot diagnose. No other test can diagnose. They can say that this is highly suspicious. In the end, it comes to a biopsy. So I want everyone to keep in mind that can someone with TH2 low risk develop breast cancer or have breast cancer? Yes, but statistically, it's very low. Just like someone with TH4 may not have any issues for the rest of their lives, but again, statistically, they may be at higher risk. Okay? Here's a case study that I want to present. This is a patient that came in March of 2010. And we looked at her right breast, and you can see that there is an asymmetrical formation just over the supraareolar area of her right breast here. She had a score of 75. Now, from March 2010, her next appointment was in January of 2011. And even though it doesn't look as kind of prominent as you've seen on the previous image, but it has become more unilateral, which is, in other words, everything we do always a contralateral comparison. In other words, if we see something on one side, we want to see something on the other side. I know symmetry in some circles is considered to be boring, but when it comes to your health, it's probably the best thing you have going for you. So her score goes up from 75 to 85. This was January 2011. She comes back in November of 2012, and now her right breast is score 150 TH5. Her nipple temperature difference was over 5 degrees Celsius between right and left nipple. I've done many of these, thousands, tens of thousands, and I've never seen something as high as the nipple temperature between these two breasts. So naturally, we asked her to escalate. She had whatever workup, probably mammography, and she was diagnosed with breast cancer. And she came back in March of 2013. Now, she had a lumpectomy on the right side, and she had chemotherapy. And she was just finishing up with chemotherapy when she came to see me. And I was astounded personally, because when I looked at the image from 5 or 6 months before to what we see now, it was amazing. In her case, it worked beautifully, and she went from 150 to 50 TH2, now low risk again. Now, I want you to remember this image and her next one. Now, this is March 2013. Now she's not waiting a year plus to come and re-image. She's coming back in just 4 or 5 months. And we're looking at July. Look how she changed. I'm going to go back for a second. And now look at this. It's almost like looking at a different person, but it's the same one. So naturally, she's lost a lot of weight. But it wasn't just a weight loss. I asked, wow, what are you doing? You look like an athlete. You also look, I didn't tell her this, but she did look fabulous. She looked 10 years younger. And she said that, actually, I'm exercising rigorously every day. My diet is very, very strict. I do all sorts of things. I said, hey, whatever works for you, continue doing this. You're definitely on the right track. Now, this was in July of 2013. Now, in October of 2014, again, right breast remains the same. However, I'm starting to see something developing all over the place here. And you can see that she's gained weight. So I tell her, we're not going in the right direction. You were doing so well. What did you change? Well, she says, I'm not exercising as frequently as I used to. And my diet was very restrictive. So, I started eating a few things here and there. Of course, she gained weight. So her score, again, right breast goes from 40 to 65. It's not a big jump, but it shows us that she's really not moving in the right direction, as previously noted when she was going kind of lowering her risk. Now, in March of 2015, the right breast is still TH2, but something is going on with the right breast. She's starting to develop new kind of formations of her blood vessels in the right breast. Again, I asked her to escalate immediately. Unfortunately, she had a recurrence in the left breast now. And we didn't have subsequent follow-up because I believe she moved to the West Coast, and maybe at some point in time we'll get together again. Now, what thermography is, as I've just illustrated, is it is a great diagnostic aid, especially when other tests are equivocal. We're not sure what it is, but come back in 6 months or a year and we'll take a look at it again. Why wait? Let's have thermography and take a look at this now. It is an early warning system, and sometimes I do realize that we may be raising a flag a little early, well, that's fine. That gives us an early warning system. And at this point in time, as I mentioned before, I would sit down with your health professional and say, how do I lower my risk? What do I need to do? So it's a great risk assessment tool, treatment monitoring, and finally a prognostic indicator. So now we have changed the paradigm because the problem has become a solution. First, every single woman needs to have thermography done to see her level of risk for developing breast disease. And then we need to look at prevention rather than early detection. So risk is always there, but we need to know where we stand as far as risk is concerned. And finally, I want to leave you with one thing, that be responsible for your health. Your doctor, your government is not responsible for your health, you are. And remember that every action counts. It doesn't have to be a drastic change. Sometimes small steps, day by day, week by week, something that you start doing, whether you are looking into a better diet, whether you start exercising, whether you need hormonal kind of balancing, whatever it is that you need, remember that every action counts. Now, I want to conclude by thanking you for your time, for listening to me. If you have any questions, you can email me directly at info@thermographyclinic.com. And if you wish to call and just say hello, please call me at 416-636-2916. Once again, thank you and enjoy the rest of the conference.
The Canadian Association of Clinical Thermography is dedicated to making thermography more accessible and available to those who seek it. Become a supporting member today and help us transform the way medical thermography is understood in our world by practitioners and the general public. Visit us today and join us.